think the decision about screening now has to be a decision that every man engages in actively. I honestly don't think you should be able to get a PSA test until you've gone through a decision-making process, and some would even say you have to, maybe even answer a couple of questions, like what do you anticipate the outcomes of this could be, and do you understand what the implications of it are? Because again, once you start down that pathway, it's harder to get off it. So I'd want men to understand that if your PSA test is positive, you're going to go on and have a biopsy. If you have a biopsy, then you need to make it, and it shows cancer, you'll need to make a decision about what to do, and have some idea that those treatments have side effects, so that about 50% of men will be impotent or incontinent after treatment with radical prostatectomy or radiation. Then you need some kind of global thing that says, and we don't know whether that will extend your life. Before, the uncertainty part was we don't know how much it will extend your life, and the range around it was wide. But with the publication of the 2 trials in the last year, now we've been able to bound it more. It's either a little bit chance of reducing your chance of dying from prostate cancer, or none. It's not large. The studies that we wrote about in the Archives editorial, one of them is a large national study of medical decisions, and what they showed was that doctors and patients aren't communicating well about the pros and the cons of PSA screening, not surprisingly. For a lot of things, when you look at studies of whether doctors and patients talk about all the potential issues around a health decision, most conversations in clinical practice tend to be on the short side and don't necessarily involve all the elements that might be important for making a well-informed decision. And that's been shown for a lot of different conditions. And again, I think because the PSA test is a blood draw, people treat it more like it's more innocuous than it really is. The Australian study, what they did was take the data from the large randomized trial in Europe, which was the more optimistic projection of the benefits of PSA screening, and then use it to produce a table that shows the consequences of screening, for a hypothetical group of 1,000 men. And in the editorial, I comment on the 60-year-old men and show the different consequences, which include an increased risk of being diagnosed with prostate cancer if you have the PSA test. That's what we call overdiagnosis. People who are given the diagnosis of prostate cancer based on some cancers that would have never gone on to become clinically obvious. And secondly, as a result of being diagnosed with prostate cancer, an increase in the chance of having treatment-related adverse effects like impotence or incontinence. And those have to be balanced against a small, about 1 in 1,000 chance over 10 years of having your life extended because of the PSA screening preventing prostate cancer-related death. The Australian group would like to give that information to patients, and they've done it before for breast cancer screening and found it to be effective in helping patients make more informed decisions about breast cancer screening. So the next step is to take a table like that for them and test it, see whether it helps inform people and helps make better decisions. Now, other people have created decision aids, including people at our own institution like Russ Harris, Stacy Sheridan, and Carol Golan. Different decision aids for the PSA screening decision. People have chosen different amounts of quantitative information versus qualitative information. And in the end, I don't think the quantitative information is by itself all that you need. You need to think about really how you feel about the outcomes. So, of course, no one wants to die from cancer, but that's only one of the outcomes. You also have to think about how you feel about being impotent or incontinent. And then there's another kind of more subtle thing, which is the downsides of screening happen early on. So if you get screened and have a cancer found, what happens is you get treated for it right then, right? And you suffer the treatment-related side effects like impotence or incontinence right then. On the other hand, if you're going to die from prostate cancer, most of those deaths occur much later. Not all of them, but some of them will occur, 5 years later, 10 years later, 15 years later. And so you also have to trade off living with the downsides of treatment for a longer period of time in order possibly to have your life extended down the road. I think the most important message for their physicians is similar, that this is an important decision that warrants discussion. Now, of course, we have to be practical. The way we have office practice organized right now, we can't sit down and have a discussion with patients for an hour every year about the next PSA test. So I think the reasonable compromise is when you reach an age, like say age 50, where you might start a PSA screening regimen, have one good discussion with your physician. In my opinion, the best way to do that is to have the patient watch a decision aid first, reach a preliminary decision, and then convey that decision to their physician. If they're, after watching the decision aid, if they're very clear, I do not want screening or I do want screening, then the discussion can be relatively brief with the physician. But if they have more questions and want to bring up certain topics that they don't feel comfortable with, then that discussion can be a little bit longer, but then it's done for one time, and then you revisit it maybe in 10 years, or if the person's health changes. And we have a grant now from the Foundation for Informed Medical Decision Making, an organization that makes decision aids, to look at ways to integrate them into practice. We're doing research on that at UNC right now. So what we found is that it's oftentimes very hard to have patients watch the decision aid while they're there for their usual visit. Because again, the PSA decision aids, range anywhere from 5 to 10 minutes up to 30 minutes in length, and finding time to have uninterrupted time to watch the whole thing is a little hard in practice. Similarly, if you send out decision aids unrelated to a primary care visit, some people watch them and some people don't, and the uptake is not particularly high. So what we found is most effective is we send out the PSA decision aid in advance of a scheduled appointment. We ask the patient to watch it at home. If they do, great. If not, we give them an opportunity to watch it in clinic. And that seems to be the best balance in terms of feasibility for us. But we need to figure out more innovative ways of getting the information to people when they want it and need it. The other problem I guess we ought to just talk about a little bit is that we have an image of cancer, and in our image of cancer, cancer is a bad disease that kills you. But what we've done because of our technology is we've expanded the spectrum of cancer so that now we're detecting a less severe end of the spectrum. So now with PSA screening or with some other technologies for other cancers, we've shifted that curve. So what we're left with is the mental image that cancer is bad and I've got to get rid of cancer. Well, it turns out with prostate cancer, the average prostate cancer isn't really all that bad, but some of them are, and that's the dilemma. So we need better research so we can really try to better figure out which ones are going to be problematic or not problematic. But in the meantime, we've got to make decisions, and this is, I think, a particularly important point for the older man. So, again, men over 70, if you don't have prostate cancer, you probably shouldn't be getting screened for it.